Hello and welcome to a special interview for The Wire. Today we present an expert view from outside India on India's struggle against the coronavirus. My guest is one of the world's great experts on public health, Professor of Global Health and Director of the Harvard Global Health Institute, Professor Ashish Jha. Professor Jha, as of today, India has over 380,000 cases and it's growing at around 13,000 a day. This means India is third largest in terms of daily increases, fourth largest both in terms of total cases and daily deaths, and eighth in terms of total fatalities. And many people in India look at these statistics and ask themselves the question, are we losing the fight against the virus? What's your answer?
Well, what I would say, and by the way, thank you for having me on, and I am very pleased to be speaking with you. What I would say is that it's very early in the battle. And so we have to take the long view. Even under the most optimistic of scenarios, we are going to be fighting this pandemic until the middle of next year. And it's hard for me to see anything much earlier than that. And so if we have another 12 months to go, we have to calibrate our response and not worry so much about are we losing or winning this week or next week. But it is how do we get through this entire pandemic in a way that minimizes loss of life, minimizes harm to the economy. And so that's the framework that I would propose. That said,
Sorry, carry on.
Let me just make one more point. That said, I am worried about where India is right now. I am worried about the upcoming weeks and months, and I have been thinking a lot about what is it that India can do because the trajectory is concerning.
I want very much to come to that important element of what it is that India can do. But first, for the audience, let me try and establish precisely why there are grounds for worry, why the trajectory looks a little depressing, if not distressing. Now, even though India has over 380,000 cases, the government insists repeatedly that we are not in community transmission. In fact, the truth is the government has gone one step further and even questions what the term community transmission means. So let me ask you a twin question. Is community transmission vague and undefined? And secondly, do you believe India has entered that stage?
You know, it's funny how much attention that term gets. Personally, I don't think it's all that important of a term, but let me be very clear. Community transmission is a simple idea, which is that the cases that you are seeing at any given moment in any city or village or town was transmitted from somebody else living in that community. That's all it means. So it's different from, all the cases are people who traveled here from Italy or Wuhan or somewhere else. That's the only important differentiation. So when we think about the 13,000 new diagnoses, new cases identified, let's say yesterday, do we think all those people traveled from outside of India? No, of course not. So if the question is there community transmission happening in India? The answer is, of course there is. Like, where else are these cases coming from? And, you know, I was recently on a show where somebody said, well, it's not nationwide. It is not every village, not every town. And I said, of course, that's true. Community transmission does not mean that every village in India has cases being transmitted. But there is no question in my mind that there is community transmission happening in India. And why this has become a focus of discussion is beyond me. I don't understand why this is so important. The important part is there is virus spreading across the country in many, many parts, and we need a national and local strategy to curtail it.
That is a very clear and unequivocal answer. Let's now come to the trajectory, which is perhaps the real cause for concern. 380,000 are the cases that are known and officially recorded. But what do you believe is the number of undetected infections that must lie behind this figure of 380,000?
Yeah, so there are many different estimates, and we don't know the exact number, of course. But I would say a few things I think are worth paying attention to. So 13,000 cases is what we are identifying on a given day in India. But if you ask the question, okay, but how many deaths? We're seeing 300 to 400 deaths a day. Let's assume for a second that we are not missing any deaths. Let's assume that mortality surveillance in India is perfect and every single death is being accounted for, which, by the way, is quite an assumption because even in the most advanced countries, surveillance for deaths are not perfect. And I'm confident that the surveillance for deaths is not perfect in India. If we had 350 deaths yesterday, approximately we did, the the infection fatality ratio for this virus is 1% or even a little less. That means that only 1 in 100 cases lead to somebody dying. So if 350 people died yesterday, that means 2 weeks ago or 3 weeks ago, because there is a lag between infection and death, about 35,000 people were infected. That's how you get to 350 deaths 2 weeks later. That would give you a 1% infection fatality rate. So the fact that 350 people died means 2 to 3 weeks ago there were 35,000 new infections. We only identified 7 or 8,000 of them. Today, my best estimate, based on modeling data, everything else, is India probably has about 50,000, 40 to 50,000 new infections happening on a daily basis. And the testing infrastructure is such that it is capturing maybe a third of those cases. 2/3 of those infections are going undetected.
So India, you believe, has something like 40 to 50,000 uncaptured infections every single day. Have I
40 to
understood
50,
correctly?
no, 40 to 50,000 total. 40 to
That,
50,000 total.
that includes 13,000 that are detected.
Exactly.
But that also means that up to 37,000 infections are happening every day that are not detected. What then do you believe will be the picture 3 months down the road in September? What number of cases are we looking at? And what number of undetected infections are we looking at?
Yeah. So if we even take the low end of that, let's say 40,000 cases a day. And again, I think that would be a very conservative estimate. I think most experts would think that there are many more than that. But even if we take a look at that 40,000, it's growing, and it's growing pretty consistently. The number of cases that India is identifying is growing every day, and the number of cases underlying it are growing every day. If we just go back to 2 weeks ago, there were about 9,000 cases a day. Now we're up to about 13, 14,000. My expectation is that in the weeks to months ahead, barring any changes in policy, and we can come back to what those changes might be, barring any changes in policy, you're going to see continued growth of cases. So number of identified cases might get to 25, 30, 40,000, but the total number of cases, and some of the most reliable models I've been looking at suggest we might get to 100 or even 200,000, 1 or 2 lakhs of cases a day by the time you're into later part of the summer, August, unless policy changes are made and unless things are done to reduce that load. That is the worry. That's the worry. Sorry, go ahead.
Just for clarity, you're saying that unless there are policy changes, and I will come to policy changes in part 2, but unless there are policy changes, you're looking at by somewhere around the middle or end of August, 25 to 30,000 detected cases a day and up to 1 lakh or 2 lakh undetected infections per day.
Per day. That's what the modeling data suggests. And my take is all of the data I have seen suggests that that's entirely possible and even likely. So there's a lot of infections ahead, and there's a lot of work to do to try to prevent that outcome. But let me actually explain why the modeling data says that and why that is almost surely to be true. Right now, let's even say we're not missing any cases. Let's say there are only 13,000 cases a day and that the surveillance system of India is perfect and capturing every case. By the way, nowhere in the world has that been true, but let's just assume for a second it is. The average person infects 3 more people, left unchecked. Okay, left unchecked. The viruses are not, which is a epidemiologic term, says that the average person infects 3 more people. Now, with many of the policies that are already in place, we don't think that level of transmission is happening. But we do think that the R naught is greater than 1. And the estimates are that it might be 1.2 or 1.3. That means the average person is infecting 1.3 people. So average person, what that does through just simple math is if you infect, let's say 2 more people, then they infect 4 more people, then it goes to 8, it goes to 16, and you get this exponential growth. When I look at case growth in India, it has that exact slope in the last couple of weeks of clear exponential growth of this virus. And that worries me because it means that left unchecked, the number of cases will every day will continue growing. And nothing, people have been asking me, when is the peak? And my point is, something's going to have to create the peak. It just will keep going until it has infected a large part of the population. So we have to have policies to slow down and stop that spread and ultimately try to bring it down.
I want to pick up on that question that you asked yourself, when is the peak? But before I come to that, let me raise another issue which could affect the peak. Yeah. Tens of millions of migrant workers have gone back to their villages in rural Bihar, UP, West Bengal, Orissa, Chhattisgarh, Jharkhand, and they've presumably taken the virus with them. And in 2 or 3 weeks, we will see a surge in the rural hinterlands. And those are also parts of the country where the healthcare system is either very weak or the infrastructure is probably missing altogether. Is that not going to be a particular problem? Because suddenly, the focus of the virus will have moved to rural India, where the capacity to tackle it will be at its weakest.
So this is an area I have been very, very worried about. I am originally from Bihar, right? I was born in Bihar. I grew up in Bihar. So I know Bihar well. And when I have looked at what has happened with migrant workers, there is no question that many of them took the virus back with them unknowingly, or maybe they had no symptoms or mild symptoms. And what is going to happen, so here is what seems likely to me based on all of the data. Right now, of course, the focal points have been the economic kind of hotspots of India, right? The Mumbai's, Delhi, places in Gujarat, Chennai. These are the places that you would expect in a global pandemic to be hit first, because that's where the international trade is, that's where the travel is. So it is not a surprise that those are the places where things have begun. But over time, as the virus spreads, we will see other places, other cities, second-tier cities, third-tier cities in terms of size, and then, of course, into the smaller district towns and villages starting to get infected. That would have a certain pace, a certain amount of time it would take for all of that to happen. Unfortunately, what happened with migrant workers has just accelerated that. So while that would have happened anyway, because there's always some amount of travel, what happened with migrant workers is accelerated that. So what I expect is over the upcoming several weeks, we're going to start seeing more cases in these places. The reason it's going to take a little bit of time is in the beginning, the virus can go undetected for quite a while. So imagine the worker from Mumbai who makes his way back to Madhubani in Bihar, which is where my family is. He might, in the first couple of weeks, infect 1 or 2 more people, who a couple of weeks later might infect 4, who might a couple of weeks later infect 8. But 8 or 16 or 20 aren't going to make a big difference. You're not going to pick it up because majority of people have mild disease. You might have one person who dies, but you don't really know why. You don't have good testing in Madhubani, and it can go undetected for many, many weeks. And so what I am convinced of is over the next few weeks, people are going to look at the data and say, oh no, there was no problem with migrant workers. We didn't have any seeding of cases. But that 8 becomes 16, becomes 32, 64, 128. At some point, you start getting hundreds. And in a town like Madhubani, I'm just picking on Madhubani because that's where my family is. Once it gets into many, many hundreds, it becomes hard to miss. And that's when it becomes apparent. It will take a while for that to happen. It would have happened anyway, but these migrant workers have accelerated this through no fault of their own. I'm not blaming them. And that's what I am very worried about in the upcoming months.
Let's then come to this question of the peak. A few days ago, the Hindu newspaper published a study done by some experts from the Indian Council of Medical Research. But I should add that as soon as it was published, the ICMR actually disowned the study. But the study said that the peak might not come till mid-November. Now that to me, prima facie, seems to accord with what you're suggesting.
Yeah, I haven't seen the study, so I can't comment on it specifically. But I would say the peak happens. There's got to be a reason why a peak happens. It doesn't just happen naturally. I mean, it does happen naturally in the sense that it happens once the number of infections gets very, very large. But we are a long ways away from that. So I do not expect a peak anytime in the upcoming days or weeks. And I certainly think it could be well into November or maybe even later, depending on what policy changes are made, what we do. The peak is dependent on us largely and our behavior and actions.
You know, I'm very tempted to come to the policy changes, but I'm going to first put to you a set of questions about the statistics that the government in India believes are reassuring and comforting, and ask you whether you agree with the government or not. I think
Okay.
after those questions, it would make sense to talk about what the government should do. Now, the
Okay.
first statistic that the Indian government finds very reassuring, and it repeats at practically every press conference, is the mortality rate. They've drilled into us that per 100,000, India's is 0.90 compared to 63 for the UK, 57 for Italy, 58 for Spain. Even in percentage terms, the government says India is only 3.3 compared to a global average of 5.6. Is the mortality rate really reassuring, or would you say different countries calculate mortality in a different way and you can't compare these rates because they're not comparable?
Yeah, I think calculating crude mortality rate by looking at how many have died versus how many people have been infected is not a useful exercise. I don't think it tells you almost anything. So let me explain why that kind of mortality rate calculation, in my mind, is not useful. So first, let's just be very clear about what a mortality rate would be. So right now in India, as I see it, there, as you said, maybe about 4 lakh or a little less than number of cases, right? That's how many we've had. About 12,000 people have died from this virus. So the mortality rate is number of deaths over number of cases. If you are missing many, many cases, right, because you're not testing enough people, then the number of cases you have is too high and your number is too high. If you found more cases, your mortality rate would come down. So the 3% mortality rate is too high. That's actually, I don't think that is India's mortality rate. But the 12,000 deaths assumes that you're capturing everybody who has died from coronavirus and that you have a surveillance system for mortality that is perfect. We don't think that's true. So there may be many more deaths that we are missing. So neither the numerator nor the denominator is reliable. One more problem with mortality rates, which is if tomorrow 13,000 people get infected, they become part of the denominator, the number of cases. But death takes 2 to 3 weeks after infection. And so there's always going to be a lag. And so until that lag is over, you don't know which of those 13,000 people will die. So it looks like all those 13,000 people are still alive today. It looks like none of them are going to die. But of course, in 2-3 weeks, some number of those will die. So this obsession with mortality rates, by the way, this is not an Indian obsession. Every country in the world loves talking about their mortality rate. And generally, most public health experts, epidemiologists, physicians and infectious disease experts, I think the entire community finds this exercise puzzling. It's not useful. It's not useful. Now, one other last point about this, and then I'll stop, is that countries' mortality rates are going to differ based on patient population. One of the hardest hit places was Northern Italy. Northern Italy has a very old population. So their mortality rate is going to be high simply because they have a lot of older people. And India has a relatively younger population. It's one of the things that assures me about India, is it has a relatively younger population. So I expect that the overall mortality rate when this whole pandemic is over will be lower in India. But I don't believe that there is some miracle therapy that India has that other countries don't that is lowering the mortality rate. I would not focus on that. I think it is a distraction.
Let me put you the second statistic that the government drills into us. This time it's the recovery rate. Now, India, with something like 12,500 deaths, has a recovery rate of 53.8. But I notice that Italy, with over 34,000 deaths, has a recovery rate of 76%, and Spain, with over 27,000 deaths, has a recovery rate of 70%. Those recovery rates are a lot better than India's, but their deaths are double or triple India's. So how reassuring is a recovery rate?
This is another statistic that is not useful. Let me explain why. Now, it seems like, of course, recovery rate should be useful. We want to look at what proportion of people recover. Here's the key point. We think for this virus, 99% of people recover. When the pandemic is over, the recovery rate of almost every country will be close to 99%. Now, you may not see it in your statistic because you may not be capturing mild cases. So if a country captures its mild cases, then its recovery rate will be higher. If it only tests very sick patients, many of whom die, its recovery rate will be lower. But there's nothing different about the treatments or actually the disease. It's just about who you're capturing in your testing. So imagine that, if you only capture your young, healthy people, they're the only ones who get tested, you will have a very high recovery rate. If you only test older, sicker people, you'll have a very low recovery rate. It tells you nothing about the disease. It just tells you about the population you're testing. Another statistic that gets a lot of attention that I wish people would not pay attention to. There are 3 or 4 statistics that are very, very important to pay attention to. Recovery rate and crude mortality rate are not among them.
Now, just about a month ago, precisely on the 23rd of May, the health minister in an interview said that the disease is not that virulent in India. That's an exact quotation, by the way. And to buttress his argument, he said that only 6.4% of Indian cases end up in hospital, only 3% need ICU treatment, and under 0.5% need ventilator support. And he said this was compared to 3% globally. Is there any scientific reason at all for believing that the strain of the virus in India is less virulent than it is in Europe or America or even the rest of the world?
No. Short answer, no. So first of all, there is an interesting question of how many strains of this virus are there. And when I speak to the leading virologists in the world, the very best virologists who are studying this virus, and I pose to them, I'm not a virologist, I'm a doctor and a public health expert, but I'm not a virologist. So when I pose to them the question, how many strains of the virus are there? You know what they almost all say to me? They say there's one. There's only one strain. So we can come back to talking about why they say that. Well, let me just say it directly. There are many mutations of a virus. Every virus has many, many mutations. That's a normal feature of viruses. But strains are really driven by functionality. Is a mutation leading to a virus becoming easier to spread? Or is it a strain leading to a virus becoming more deadly? We have not seen any convincing data that different mutations of this virus had led to some mutations causing the virus to be more deadly, or some mutations to become easier to spread. It is possible, we just haven't seen that yet in the evidence. So that's one issue. And therefore, I have no evidence that India has a milder strain or a deadlier strain. I don't even know that there are milder or deadlier strains. And so to begin with that assumption, I think is very problematic, is not based in science. The second part of this is that people have said to me and others, maybe Indians have some sort of natural immunity to this virus. I have no reasons to believe that based on my ethnic background, I am going to be less susceptible to this virus than somebody who is Italian or somebody who's Chinese or somebody who's German.
Can I interrupt at that point? It's often said that the fact that the BCG vaccine is given on a compulsory basis in India has given India a level of immunity that other countries don't. In Italy, it was compulsory but stopped being compulsory somewhere in the 70s. Something similar is true of Spain. And people take the example of Portugal versus Spain. In Spain, it's not compulsory. In Portugal, it still is. And the incidence in Portugal is very different. Do you think BCG could be a factor in India, or are we just giving ourselves hope but there's no scientific reason for it?
So I want to say, let's talk about the science of BCG vaccine and coronavirus. So far, there is no evidence that BCG vaccine is protective. So far, but let's dig into it a bit more. There is evidence that BCG vaccines can be what we call immunomodulatory, meaning that with some respiratory viruses, people who've gotten a BCG vaccine sometimes do appear to have milder forms of the disease. There is some evidence for that. And so it would stand to reason that BCG vaccination could lead to a milder form of coronavirus. So theoretically and scientifically, that is possible. Possible is not the same as we have evidence it's happening, but it is possible. Now, if we go to the evidence and say, what's the data tell us as opposed to theoretical evidence? There is now increasing amounts of data that having gotten BCG vaccine 30, 40, 50 years ago. So I got a BCG vaccine when I was a child living in Patna. And it is theoretically possible, but here's the evidence. There's that like getting BCG vaccine 30, 40, 50 years ago, there's no evidence that that is protective against coronavirus today. What people are experimenting with is, what if I give out BCG vaccine now? So what if we do a mass BCG vaccine campaign now? Might it protect people against more severe forms of the disease? Those clinical trials are ongoing, and I think in the next month or two we will know. My best read of the evidence is that BCG vaccines, having gotten it 30 or 40 years ago, as I did, probably is not going to protect me from this virus. But we don't know for sure, and we have to look at the data. Picking individual countries is always interesting. There's a lot of reasons why Spain got hit harder than Portugal. BCG vaccine may be one of them, but I'm skeptical that this will end up playing a major role.
One more issue before I come to that critical question of what are the steps the government should take. And this time it's an issue that in a sense you touched upon yourself a little while ago. The epidemiologists that I've spoken to previously, I refer to Sunetra Gupta from Oxford as well as Jayaprakash Mulial in Vellore, have said to me that India's real strength lies in the age profile of its population, the fact that 90% are under the age of 60. And they say that this means that if this age profile is infected, they will either be asymptomatic or so mildly affected, it won't really affect them. And therefore they conclude that the strategy for India is to protect the elderly, protect those with comorbidities, but let this 60% who are under 90, the other way around, 90% who are under 60, go out and lead a normal life, wearing, of course, masks and keeping social distancing. Would you agree with that general viewpoint?
So this is a very risky strategy that is being outlined. And let me lay out why. First, we don't know what that means to protect people over the age of 60. So it turns out in India, people live in multi-generational households, as you know. And so what will we do with our elderly? Will we put them on a boat and ship them off somewhere for 1 year? Like, we have to do something with what it means to protect them. We have to make sure people get food. We have to make sure people get clothing. We cannot separate out the one part of the population from another. So you may say, okay, if you're a 35-year-old woman who's working in the technology industry, go to your work, and it doesn't matter if you get infected. It may not. But you might come home And you might then give it to your child or your husband or your someone else who then could infect an elderly person. Or you might come home and you might live with your parents or your in-laws and you could give it to them. So this idea of protecting the elderly sounds exactly right. This has come up over and over again. Sweden has thought about this. UK for a little while was planning this. Lots of countries come up with this idea, but then no one knows how to execute on it. That's one major problem. Second major problem is that we don't know that much about this virus. And increasingly, we are seeing that there are people who get infected, young people, who may not die, but suffer a lot of long-term consequences. We don't know how long-term because we've only had this virus in our world for 5-6 months. But we are seeing people with chronic inflammatory conditions, other debilitating things, people having heart attacks and strokes in their 30s and 40s. So I don't want to be so cavalier as to say, go ahead and get infected. If you have a stroke or a heart attack, at least you'll survive. I want to be much more careful. I don't think we know enough about this virus to be that comfortable making such proclamations.
Can I quickly pick up on that last point? I noticed that on the 20th of May, that's exactly a month ago, the Indian Health Ministry released details which say that 48.8% of COVID deaths in India were people under the age of 60. I also noticed from the WHO statistics that in Europe, the percentage of people who died under 60 was just 5. So in India, actually, what you expect to happen is not happening. Our deaths under 60 in percentage terms seem to be 12 times worse than Europe. And that brings to my mind the question, can we really rely on the young as a strength to save us? Or are we overestimating that?
I think it's very risky to say we will let everybody under 60 get infected and not worry. I think what are likely to see, well, first of all, I will say one more thing. The leading experts that I spend my time talking to, and I obviously spend a lot of time studying this pandemic and how it's going, but the people that I trust to talk to, most of them feel that they understand this virus less now than they did 1 month ago. What I will say, even though the science has gotten better, meaning there is so much uncertainty. And so anyone who comes to you and says, I have a very clear policy, it's very definitive, this is the right answer, I would be very skeptical of. I myself don't feel like I have almost any of the right answers. I have some ideas and I can tell you what the science is today. But we have to be very humble about this virus. In terms of young people in India, I've seen those statistics of a lot of young people making up a large proportion of people who die. It's very troubling. I don't understand it fully. What we know is that it's not just age that is a risk factor. So is high blood pressure. So is diabetes. So is having kind of these chronic conditions. What we know about Indians as a people is we have high rates of heart disease. We have high rates of high blood pressure. And so it is not clear to me that a 55-year-old woman or a 50-year-old man with high blood pressure and diabetes in India is somehow safe from this virus. In fact, I would suspect they may not be. And I think we have to be much more careful about such proclamations, lest we see many people get very sick and die.
Professor John, let's take a very quick break at that point. When I come back, I want to turn to that critical question. What are the steps the Indian government should take, particularly if in 3 months' time, we could be experiencing something like 1 lakh or 2 lakh undetected infections every single day? We'll be back in a moment's time, but first, a quick break. Welcome back to a special interview with The Wire. My guest is one of the world's most highly regarded public health experts, Professor of Global Health and Director of the Harvard Global Health Institute, Ashish Jha. Professor Jha, if you're right in saying that today we have something like 40 to 50,000 undetected infections, and in 3 months we could have perhaps as many as 2 lakh undetected infections every single day, What then are the critical steps the government must take?
Yeah, and let me clarify. I think there are a total of 40 to 50,000 undetected and detected. So the 13,000 detected and maybe 20 to 30,000 undetected. Right. And we are in a situation in India where the number of cases is rising every day. Number of new cases is rising every day. And we're in a very concerning trajectory. So let's lay out basic principles of virus control, what we know as of right now, and then let's think about how they would be applied in the Indian context. So, what prevents the spread of this virus? Well, we know that left unchecked, if you do nothing, the average infected person will infect three other people. And that those three will infect 9 and 27, and you'll get this massive growth. That's left unchecked. So, what kinds of things can bring those numbers down? Social distancing is number one. Having people not spend a lot of time together in close proximity. Second, there is emerging evidence that being outdoors is better than being indoors. So a large crowd indoors is much, much more dangerous than a large crowd outdoors. Large crowd outdoors is still dangerous because you have that close proximity, but being outdoors is safer than being indoors. What else do we know? More and more evidence that mask wearing is quite useful. 2 months ago, we did not have this evidence. Even 2 months ago, when people asked me about masks, I said, I don't have the evidence, I don't know. But now the evidence is becoming very good, not perfect, because nothing is perfect in this pandemic, but very good evidence that wearing masks can dramatically lower infections and maybe the severity of those infections. And then the last but not least is we know that an aggressive testing, tracing, isolation strategy can work to bring the level of virus down in a community and bring the virus outbreak under control. We know that many countries, to Vietnam, to Germany, have used these kinds of strategies, and that is the last of those things. So those four things, right? Minimize large gatherings. If you're going to have gatherings at all, keep it outside. Wearing masks and a very aggressive testing, tracing, and supportive isolation strategy. Okay, those are your four choices. How might that be applied to India? Obviously, the most extreme form of social distancing is a lockdown. And that's what India did. I have been on the record many times in public, and I will say again today, I think the lockdown that India did was a good one. It was a right policy decision. It was a very aggressive policy decision. And it was in many ways bolder than most countries have been. And I applauded the Indian government then, and I applaud it now for that decision. I think that was very bold. But what a lockdown does, it's one of the few strategies we have, that extreme social distancing, is it buys you time. So you want to use that lockdown to think about your strategy for containment once you come out of lockdown, because you can't stay in lockdown forever. And so now the other strategies that are left are, I think India should move towards universal masking, basically saying to the entire nation, everybody, when they are out and about, should be wearing a mask. If you go into a store, you should be wearing a mask. If you go into an office, you should be wearing a mask. Everybody should be wearing a mask. That's one. I think it's a relatively cheap and easy policy, and we should adopt it. And I think it can end up making a big difference. Second is we've got to get rid of any large gatherings. So no melas, not for the next 12 months. Indoor or outdoor, completely nothing indoors, right? So we've all been, I've many times into a temple, and the temple is jam-packed indoors with 500 people or we cannot have those, because those can become super spreading events where one infected person can potentially infect 50 or 100 others and can set off a very large outbreak in the community. So avoiding large gatherings, particularly indoors. And then you're really left with one last thing, which I have been speaking about quite aggressively for months, which is India has a good testing infrastructure. It is nowhere near where it needs to be to contain this virus. We have to ramp up testing a lot. And then along with testing comes that tracing infrastructure. So let me stop there and say those are your major strategies.
Let me pick you up on the testing. Everyone in India does also agree that we need to ramp up testing, and in particular RT-PCR testing. But do we need to focus on the urban containment zones, which are called hotspots in India, or do we need to also spend perhaps as much time on the rural areas where the migrants might have taken the virus and where it could spread, particularly in areas where our health infrastructure is weak? So do we need to make sure that the ramping up of RT-PCR is done strategically and sensibly to cover both existing urban hotspots as well as potential future rural ones?
So I think you've actually laid out a very good answer to your question, which is the answer is yes, we need to do both. We need to do both for two reasons. Obviously, you need to do it in the urban hotspots to identify and try to bring the hotspots under control. But second is you do need to start really thinking about surveillance and testing in more rural areas. In the example that I gave earlier of the migrant workers who might come back to Bihar, who might come back to Madhubani, as I said, they can spread for weeks and weeks. And unless you have good testing in district towns like Madhubani and Darbhanga and other parts of Bihar and Jharkhand and UP, those cases are going to go undetected. And by the time you detect it, you will have massive outbreaks. So a key part of the strategy is getting testing widely deployed, even in areas where you don't think there are many cases, to do surveillance, to pick up these outbreaks early. Because once you get to hundreds and hundreds of people or thousands of people infected, that's really late and it's going to be harder to manage.
When you talk of surveillance, particularly in rural areas, are you talking of serological surveillance surveys done periodically and regularly so that you have a constant developing map of where you think the virus is going and how it's spreading? Is that what you have in mind?
No, so I would love that. I believe in serologic surveillance as a way to map out where the virus has been. But remember, serologic surveys, antibody testing, is essentially looking in the rearview mirror. It's saying, where was the virus 2 weeks ago, 4 weeks ago, 6 weeks ago? Very important because you can see a map. But what I am talking about is surveillance using RT-PCR. This is not something people don't usually combine those two ideas, but I will. What you can do increasingly is you could imagine going to a district town, having RT-PCR capacity in that town, and then doing sampling of people, random sampling of people. There are these things called pooled sampling where you can take 100 people and get their samples and then run one test and see. And if all of them are negative, then you have a very good sense that there's not a lot of virus, active virus in that community. I would like to see India do a combination of both serologic surveillance and surveillance for the active virus and combine them into really tracking where the virus is spreading across the country.
We're coming to the end of this interview, Professor Jha, but I must ask you two more questions. You know the Indian healthcare system. Can it cope in a situation where you could be experiencing 1 lakh or 2 lakh infections every single day? And that might be happening in 2 or 3 months' time. It's not something that's far away.
So we haven't talked about this issue at all, and it is a source of both frustration and concern for me. And let me explain. India has for years, decades, underinvested in healthcare. Our healthcare infrastructure is quite weak, and this is not a new phenomenon. We've known about this for a long time. If you look at healthcare spending as a percentage of GDP, India's is quite low. And then we know, and again, staying with populous, poor states like Bihar and UP, but really across India, you have a large infrastructure of informal healthcare workers, the people that sometimes get called quacks, but they represent, in some places, half of all the people who are providing care for patients. And so we've got this workforce that we have not developed and trained. We have not figured out how to deliver primary care. And we have a hospital network, public hospitals often quite weak. Private hospitals have done well and are growing, but majority of Indians can't afford to get care in these private hospitals. We have not put in the time and energy to develop the kind of health system that India needs. Unfortunately, This virus is going to test all of those issues. It's going to put a huge strain on primary care. It's going to put a huge strain on hospitals. I am very worried that it is going to cause many, many doctors and nurses to get very sick, and some of them even die. And that will be calamitous for India because India already doesn't have enough doctors and nurses. And if many of the frontline workers, healthcare workers, end up getting infected and many of them end up getting quite sick or dying, that would be devastating for the system. So a major part of the priority has to be to protect healthcare workers because they are very precious. And if we lose them, then our ability to fight this virus becomes quite problematic.
My last question. I fully understand the need to protect healthcare workers, but there's a different problem that we hear about every single day. An acute shortage of beds, an acute shortage of doctors and nurses, and increasingly an acute shortage of necessary equipment, whether it's ventilators or oxygen. Can this be wrapped up expeditiously between now and November when the peak may happen? Is it possible to do it?
The one part of the problem is that we are in a global pandemic. So it isn't so easy for India to say, well, we can always go buy ventilators from China or buy it from other. Very difficult because everybody is looking for ventilators. So India is going to have to, whatever it does, it's going to have to do it more or less through self-reliance, even though these are global supply chains. Now, India, of all countries, of all sort of, nations around the world, India, I think, is one of the most advantaged in its incredible capacity on various issues. So it has a great technology industry. It has a very strong industry in biotech and pharmaceuticals, etc. So there are advantages India has that I think help. Can it do it? This is the whole point. When lockdown was happening, I assumed, and I'm still assuming, that we were using that time to ramp up production of ventilators and ramp up production of personal protective equipment, ramp up production of medicines. India has to. It's going to be difficult, but it must make that a number one priority, because if the health system collapses, there will be many more deaths, not just from coronavirus, but from everything else.
There's no doubt that India did ramp up very effectively the production of PPEs, the supply of ventilators. The problem is you can't ramp up the production of doctors that quickly. No. They take years to train, or nurses. And the other problem is that we've increased hospital beds from 9,000 to 20,000, to take Delhi as an example. But the chief minister is predicting that by the end of July or August, we could need 150,000. So an increase of 20,000 is nowhere near enough. What do we do about doctors, nurses, and hospital beds? Or is there nothing we can do?
Well, it's not easy. You're absolutely right. There's no magic formula. You're not going to import doctors from other countries. Again, a global pandemic means they are in short supply everywhere. There are strategies you can use. You can take other healthcare workers and work on training them so that they can at least manage some of the things that we might have normally had doctors and nurses do. It's not a perfect solution, but I do think we need to really start working on how do we broaden the landscape of who is available to work, and how do we do it. But that's not a great answer for you, because there are no great answers here. This is a very difficult situation.
3 or 4 days ago, the government said that they were going to introduce telemedicine for the running of ICUs. And they also said that they would have 30 to 40 hours training so that doctors could become intensivists. Can 30, 40 hours training convert a doctor into an intensivist? And can telemedicine platforms get ICUs in rural Bihar or rural Bengal to function? Or is this a little bit of, forgive my language, a pipe dream?
I will give it more credit than a pipe dream. I do think it can help. Can you train somebody to become a full-fledged intensivist in 40 hours? No, it takes years. But can you train them to understand the basics of intensive care? A doctor who's got medical training, could you make them understand basics of intensive care in 40 hours? You probably could. And would it help? I think it would help. It won't be a perfect solution, but we are not looking for perfect solutions at this point. We're looking for things that can be helpful. I think both of those ideas, both telemedicine, training up of intensivists, are good ideas. They will make the situation better. We should do more of that. We have to find a way to get through the next year. And the bottom line is, we are not with a lot of great ideas and great solutions. So things that help along the way, I am very supportive of, even if they're not perfect.
When do you expect a virus to have a vaccine? Normally, vaccines take 2 to 3 years. People are hoping, in this instance, because it's a pandemic, it can be speeded up and we could have one by a year's time. Do you think that's a realistic expectation, or is that just a hope?
Yeah, so usually, as you said, I mean, vaccines take many, many years to develop. I am actually very optimistic we will have one next year. It is important to know that there are other public health experts who think I am too optimistic and say to me, Ashish, you need to tamp down your expectation with maybe till 2022 or 23 before we have one. I don't think so. I'm pretty confident we will have a vaccine next year. And let me explain why. This is a virus that I think clearly elicits an immune response. And I think we know the major components of what causes an immune response from this virus. There is an unprecedented effort to do vaccine development. Over 100 vaccine candidates have been developed. 12 are already in clinical trials, and a couple of them are far along. I don't know which vaccine is going to work. I don't know if it'll be one of the European ones, one of the American ones, one of the Chinese ones, but I actually feel pretty confident that we will go into 2021, early next year, with 3 or 4 vaccines that look like they're working. And then the challenge will be to assure safety, produce billions of doses for the world, and to do it in a way that people feel comfortable taking it. Those are big challenges. So I expect all of that to be widely available by next summer. But I'm always reminded that I am more optimistic than the average expert in this. I hope I am right. I hope that, in fact, it comes earlier than that. But that's my best guess.
I think it's right to end what for many will be a fairly startling, if not at times shocking interview because of the statistics that you've given us, on an optimistic note. What it means, if you're right, is we only have to live for one more year before the world becomes safe. Thank you very much for the candor with which you've spoken to us. Thank you very much for the time that you made available. Take care and stay safe.
Thank you very much, and please stay safe as well.
Thank you.
To receive instant updates on all videos from The Wire, click the subscribe button and hit the bell icon. Pay to support independent journalism. Click the link in the description and choose the amount you want to pay.